entire adjacent toe. Generally, that's what they do. Yeah. And then from top to bottom, you want to include at least half of the metatarsal bones. And then now the alternate to this, I jumped ahead a little bit here. The alternate to this would be, instead of angling the tube, we would place their foot on a sponge. It's going to be about a 10-degree sponge with a perpendicular central ray, but you're probably not going to do this. You can, but you're probably not going to do it. You'll probably go back to doing this instead.
Why is that one specific to the second digit?
Pardon me?
Why is that one specific to the second digit?
It's not. This applies to all the digits.
The second one, I mean.
This one here?
Yeah.
It doesn't. It applies to all the digits.
Okay.
Yeah. They're just showing you an example here using the second digit, but this applies to all of them.
And that's how you position the foot with like the heel off the IR?
Well, yeah, because it's not going to fit on the image receptor, so that's not.
Oh, okay.
Yeah. That's just, it's happened because it doesn't fit on the cassette.
Oh, okay.
That's all. Okay. So again, you can just do this with a central ray, but angling the anatomy instead. Okay. Now, I think just like in the hand, yes.
For the new room, for the wall bucky, we can like turn it and everything. Like we can put it at a 90-degree angle facing down, right?
I think so. Yes.
Would we be able to?
You can also do that in the back room.
Oh, would we be able to take a foot X-ray of a person just standing up with the cassette on the ground?
No. Well.
She's wondering if the wall bucky comes down low enough to where you could just place your
Well,
foot
we're
on
not going to
top
use the
of it.
bucky for the foot.
Oh wait, not.
Yeah,
the
we're gonna
wall.
do
Yeah,
table.
never mind. But would we? Okay. The X-ray tube, like, can it come down low enough? I was gonna.
It probably can. I mean, are you asking? Well, we're not going to use the wall bucky and place
No, I
it
know,
down.
I
You can just put the
was
image
getting
receptor
confused.
on the ground, and they can put their foot on top of that.
Okay.
Yeah, you can do that.
I was first thought.
Yeah.
I was getting confused. Like,
Yeah.
the wall.
Or again,
The X-ray
best
tube.
we just put them on the table. Put the table. Yeah, put them on the table, and then they can place their foot on top of the image receptor instead of on the ground.
Okay.
But I mean, there are some instances where we do have them standing up, and you would have to take it on the ground. So you're actually not far from that. But in this case, we'll just do it on the table. Okay. Also, I wanted to note here that the pictures are going to be a little bit weird in that you'll notice that the anatomy is not placed on the image receptor, right in the middle of the image receptor, because again, back in the day, we used to use just one cassette, and we take 3 projections on
So that's
one
why it's
image
cross?
receptor. That's why it looks the way it does.
That's what they're doing it crosswise, right? Instead of
Yes.
length?
Yeah. So we can do 3 projections on one image receptor. But you won't be doing that. Again, the key here is place the part in the middle of the image receptor and then take your x-rays right there. So if you're going to do 3 shots, although we've been practicing exposing 3 shots on one image receptor, that's not the way it's done out in the field. Okay? We were doing this simply just to expedite the lab, okay, because we only had one room. We didn't have a lot of image receptors or cassettes. Yes?
So for that, we could use the circuit be lengthwise towards the toes? Or
Oh, it doesn't matter.
what does it matter?
In this case, it doesn't matter. So you can put it lengthwise or crosswise. Now, actually, I'm going to take that back. You're probably going to do it lengthwise. So this cassette would be flipped this way, and then you would put that thick part of the cassette on the top. Because again, remember that thick marking on the image receptor that gives you the indication of where the top of the display screen is. All right. So the toe should point to the thick line on your image receptor. So when it's processed, the toes are going to be pointing upward. So just like the hand, on the foot, the toe should also be pointing upward on the finished display. Yes.
The book has it as a 10 by 8 landscape, so we should.
It doesn't matter.
Okay.
It really doesn't matter. Yeah. But again, I suggest is that you probably want to get the thick marker part towards the toe. So again, when it's processed, the toe points up. Remember what I told you guys, what we say and what the book says and what's going to be done out there. It may be 2 different things. All right. So Digits and minimum of distal half of the metatarsals are going to be displayed. Open up your marker, open up your collimator enough to show your anatomical markers. So open up the collimation enough to include your anatomical markers. There is not going to be no overlap of the soft tissue or the bones. And the interphalangeal and the metatarsal phalangeal joints should be open. The interphalangeal and the metatarsal phalangeal joint should be open. Okay? Next one here is the oblique. The oblique. Just like the hand. Depending on what digit or what phalange you're going to take an x-ray of, will determine your rotation. So for a medial rotation, approximate rotation of the foot is going to be between 30 to 45 degrees. 30 to 45 degrees. So for the first, second, and third digit, you're going to do a medial rotation. Medial rotation, knee in. Knee rotated in. Medial rotation. Okay? You want to get the anatomy as close to the image receptor as possible. Okay? So this applies again, medial rotation to the first, second, and third. Open it up again to include the adjacent toes. Up and down to include half of the metatarsals. For the fourth and fifth, we're going to do an external or lateral rotation. Same applies. Open up your collimation to include adjacent toes, and up and down to include half of the metatarsals. Okay? Now, here is where it changes a little bit. Remember when you were doing an AP, you had the angulation to open up the joint space. When you're rotating the foot, the joint space starts to open, so you don't have to use an angulation. Now it's just strictly perpendicular. Okay? So angle for an AP, perpendicular for an oblique. So to accomplish these positions, you can either have your patient laying down with their knee bent. Okay, so laying down with their knee bent so the plantar surface is on the image receptor. Okay? In this case over here, in this particular image, you can see that the leg is crossed. There's a good chance that this patient here is sitting up. So they can also be sitting up for this, as long as the plantar surface is close to the image receptor. Now, with that said, when your knee is bent to put the bottom of your foot on the image receptor, okay, now you have to take in consideration modesty, and you want to cover up their private parts, okay, as best as you can. All right. Digits and minimum of a distal half of the metatarsals are going to be demonstrated. Interphalangeal and metatarsal phalangeal joints will appear open. Okay, remember the criteria like in the hand, we were talking about the metacarpals. Well, now here we have the metatarsals, in which there's going to be slight concavity on one side and more straightening on the opposite side of the shaft. The heads of the metacarpals should not overlap. The heads of the metacarpals, metatarsal's metacarpals.
Class is over.
Yeah, I know.
We're done.
Head of the metatarsals. This is the slide that we got from the company. Okay, the head of the metatarsals should not overlap. All these years that I've had this, I just caught this now. And nobody's questioned me about it.
Isn't 1 and 2 slightly overlap though?
There
you
is
would say?
slightly overlap, but this
But-
shouldn't be.
okay.
Again, if there's just slight, not a big deal.
But the majority of them should not overlap, is
Yeah.
what you're saying. Okay.
Yeah. Okay, questions? All right.
What the hell?
Lateral. Lateral.
Really touching. That's no joke.
Yeah,
You can
you
get
literally
gloves.
have
There's
to.
gloves in the department.
Always use gloves.
Okay, so this is the lateral.
Double glove.
So lateral medial, you're entering through the lateral aspect and exiting the medial, lateral medial. Okay, your knee is going to be turned in, so now it's going to be like this. You're going to be like this on the table. All right.
Now you have tape
Lateral
on the bottom
medial
of
applies
your
to the
shoe. Now you
first,
have- now you
second,
have tape
and the
on the
third.
bottom of your shoe.
Want me to do that again?
No, you,
Oh.
you have tape on the bottom of your shoe now.
As long as it's not tissue paper. We're good.
From the bathroom, that'd
I
be
know.
nasty.
Or hanging out of my pants. All right, so the lateral medial lateral applies to the first, second, and third digit. Unlike the fingers where you can easily separate the digits, we're going to need a little aid in separating the toes.
A slingshot?
Okay, so this is where tape comes in handy. Okay, this is where a tongue depressor can come in handy. This is where a pen or a pencil can come in handy.
Throw that
Using
thing
that
away.
again. Yeah.
Throw that thing away.
So this is one way of separating and isolating the toes is by use of some kind of strap, tourniquet, maybe some tape. They've also done it here with gauze to separate the rest of the toes. Okay. What I like to do is when I was doing toes, I would have them try to cringe their toes as much as possible and then have them assist by pushing the other toe out with a pen or a pencil. Okay? Cringe, and then pushing the isolated toe with a pen or a pencil. That was the way I did it.
So you would have them push their toe out with the pen?
They would do it. Yeah, so you would ask for their assistance. Okay? If they can't, if they're inebriated or if they're unconscious or unable to follow directions, now you're going to have to use some creativity in trying to isolate those toes. I know.
Is it so that the tape's radiolucent? It won't show up on the.
It's not going to show up. I mean, it may a little bit, but it's not going to show up as much. Okay? So lateral medial, first, second, and third. Okay? The central ray is going to be directed at the interphalangeal joint for the first, and then the proximal interphalangeal joint for toes 2 and 3.
2 to 5.
Yeah, but this is just for first, second. and
We're
third.
doing first. Yeah, we're still doing the lateral medial projection. Okay. For the yeah. For digits. It is. For digits 4 and 5. Digits 4 and 5. So again, you got to use creativity and some ingenuity, whatever that word I'm looking for. But you got to be able to isolate those toes. Okay.
Oh my God.
Again, pen, pencil, tongue depressor, tape, gauze. What else can we put in there?
A Lego.
Gum, a piece of fruit, a toothpick,
A Lego?
a Lego. Actually, that's not a bad idea.
Lego?
Yeah, carry a piece of Lego with you. You know the thin ones,
Got
not the
the-
block ones, but the thin ones. That actually okay.
Like that.
All right, so medial lateral is for digits 4 and 5. Central ray for 4 and 5 is going to be at the proximal interphalangeal joint, the pit. All right.
I'm like, if it's broken, how are you gonna put the pen in the middle of it?
If it's broken, then you probably, okay, so the key here is you try to get them to do as much as they can. Okay? You will know by the way they respond to the different positions, or if you're trying to help them with position. If they're in too much pain, then you're going to stop. And then you would do an alternate view somewhere between a lateral and an oblique to get as steep as possible, close to a lateral, without having them to manipulate the extremity. Okay, you guys hear that? So what if it's broken? If it's broken, then you wouldn't attempt that. But trust me, even if it's broken, you can still get them to provide you with those positions. I've had people with broken toes and they were still able to accomplish those positions. Yes?
How common are toe x-rays?
How come on a toe X-rays?
How often are we going to be touching feet?
Please give her a right answer.
They're pretty common. They're pretty common.
Going home with some stinky hands.
Yeah. They're pretty common. Because think about this. How many times have you been walking in the dark and you
Stub the hell out of your toe.
Yeah, you stubbed your toe on a piece of furniture.
I have a broken toe, like that makes it, it's not worth it because there's not much you can do about it.
Well, that's true. But again, the doctors are still going to want to take X-rays. Yeah. Your doctor said let's not do it?
Pardon?
Your doctor said let's not take an X-ray? No, that's true. If it's broken, there's really nothing that you can do about it. What they do is they just put a splint around it, or they just tie or wrap your toe to the other toe. That's the most commonly what they do for the toe. And then they give you a little a boot to prevent any additional injury.
I was about to say the same thing. I fractured my toe, and the doctor just said just body wrap it.
Yeah, there's not. Yeah, you actually don't. They say stay off your feet, wear a boot. Okay, it's gonna hurt.
Keep your feet high.
Yeah,
Whatever.
elevate your feet. My ex-wife. Okay, this was years ago. Okay, my ex-wife. We took my oldest son. Well, my second oldest son now, but he was young at the time. We took him rollerblading, and on our way home he fell asleep. So he still had his rollerblades on. I don't know if you guys are familiar with rollerblades, but it looks like a ski boot, and the back of it are the brakes. So they stick out maybe about 2 or 3 inches away from the skating boot. Okay, so it looks like the opposite end of the hammer. You got the hammerhead, and you've got the 2 prongs that stick out. Okay, that's what it looks like. So when my ex went to go wake up my son, okay, it was in the back of our van. He went to wake up our son. He threw a tantrum, and he started doing his feet like this, and her toe got smashed.
Her toe.
Her toe got
Oh, I'd be
smashed.
pissed.
So it was literally like taking the hammer and
You little
smashing her
shit.
toe. And so, again, working in X-ray, I said let's go to X-ray. Well, I bypassed all the emergency room and everything like that. I'm telling you stuff that shouldn't be done. This is silly, because I did an X-ray on her without any orders, because I just wanted to see if it was fractured, and it was. It was literally crushed in three different places of her big toe. And then I went to my ER doctor friend. I said, "What do you? I mean," I said, "I took X-rays. It's broken." And he took a look at it. He goes, "Yeah, it's broken." I said, "What can you do about it?" He goes, "Just tape it. Just tape it." I said, "Okay." And it was black and blue, and it turned pretty black and blue after a couple of weeks. But there's nothing you can do about it.
So don't break your
Yeah,
toe.
Looking
You're
back,
gonna delete
looking
that.
back
Yeah.
at it now, it's pretty funny.
I'll mute that part out.
Yeah, my son, he was playing hockey at 3 years old. So this is my son. I have a son who's 26 years old right now, and he started playing hockey when he was 3 years old, playing with an 8, 9-year-old. And he literally, when he was this close to getting to the NHL, but he was scouted as being inconsistent. And I knew that, and my ex was banking on him becoming a professional player, and I was not, and I was trying to steer him to the approach of at least getting a college education, and she kept jumping in and says, "No, we're going to do it this way, and this way, and like, no, we're going to screw up his life if he doesn't have that education." And so he was playing for the semi-pros up until he was 22. Of his group of friends, I think there was a total of 4 of them that made it to the NHL. So he was scouted as being consistent. But let me tell you this, not because he's my son, he is probably one of the best hockey players out there, okay, when he was at his game. But he was skating at 4, and so I had to build his own hockey skating boots so that he can compete, because his feet were so small, they didn't make hockey skates for him at that age. So I had to make him his own. But anyways, yeah, so he topped off, and he wasn't drafted, and so he still plays hockey, but he coaches and things like that, but he doesn't play professionally. So
So don't break your toe.
don't break your toe. Don't.
Or smash your
and,
mom.
you know,
Yeah.
when you're talking about the amount of investment that you put towards your son, I mean, when you look at the money that we did, because we were traveling all over the United States and all over the country playing hockey. He did play in Canada, he did play in Europe, and the money that we spent on plane fares, room and board, it was ridiculous. I mean, we're talking about over 500 grand, $500,000, hoping that he would, turn professional.
Now what does he do? Just.
Well, now what does he do? He sleeps a lot. He's a.
Oh, you got one of those degrees, huh?
He's a
Yeah, he's a
photographer.
photographer. Yeah.
Hey, would you do our painting
Yeah,
ceremony
he
for
can.
free?
For,
He's a photographer.
for free?
Yeah.
She's already
Good
doing
food.
it.
I showed a picture of Evelyn to him.
I was like, where's he been?
Yeah. I'm like, hey,
It's
stop.
too late now.
I'm like, you're married, stop. Yeah. All right. Where were we? Oh, smashed toes. Okay, so medial lateral, fourth and fifth digit. Okay, any questions here?
What the hell?
That's impressive.
Oh.
Sweet.
I thought that was a Twinkie. like that a Twinkie?
You say, is this cheese?
That's
Cheese? Oh.
That's too flavorful.
It like flipped me off.
How cute.
All right, so digits. Digits presented in true
That's
lateral
such a cute
position.
X-ray.
Right?
Interphalangeal and metatarsal phalangeal joints are going to appear open, digit free of superimposition. Okay, so you're going to have some superimposition of the proximal part of the toe, and also the metatarsals, but the distal and the middle phalanx should be free of superimposition. Okay. Oh, let's not do that. Let's not do that. Okay. So that's the toes. Foot. AP projection of the foot. So again, this is actually a good picture of someone who's having a foot x-ray. So they can either be lying down or they can be sitting up. The objective is to get the plantar surface on the image receptor. We put a sandbag here to prevent any type of moving or shifting of the image receptor. Just like in the toes, you're going to use a 10-degree angulation towards the heel, and the central ray is going to be directed at the base of the third metatarsal. Okay? How do we know if we've got all the anatomy that we want? Okay, so you're going to collimate tightly on all four sides. What is it that we're looking at to make sure that we've got all the anatomy in there? We're looking at the shadow, okay? So again, refer to the shadow to make sure you've got the anatomy centralized to the field, okay? You'll notice here that the marker was placed on the lateral aspect. We've been teaching you guys put the lateral on the thumb side. Now you're going to put the
side.
marker on the pinky side. All right? Entire foot is going to be visualized with no rotation of the metatarsals. The metatarsal phalangeal joints are going to be open because of that angulation of approximately 10 degrees towards the heel. Now, you guys are lucky in that when you're taking x-rays of the foot, you will have consistent density throughout. We don't have it here because it's thinner towards the toes and thicker towards the heel, so that's why there's a change in density. Yes?
For the 10 to 15 angulation of
I
the
need you to
foot-
speak up. I can't hear
For
you.
the 10 to 15 angulation of the foot, are we dropping the glute like you need to?
Probably not.
Just because it's such a small degree.
Yeah, again, it's such a small angulation, it doesn't make a difference. I think I only mentioned this to half the class. Do you understand the whole purpose of lowering your SID when you have steep angles?
Yeah.
Okay, it was more. It had more of a meaning when we were doing film. Because if you didn't account for that increase in SID when you have steep angles and you kept your technical factors the same, you would end up with an image that's very light. Okay? So now that you have digital and computerized radiography, the software program takes care of it for you. But now you got to think about it in the viewpoint of patient exposure. So you think about this. If I have a steep angle, let's say 30 degrees and up, okay, now you increase your SID substantially by maybe 2, maybe 3 inches. If you don't adjust your SID for that increased distance, the beam intensity is going to be less, which means now what happens to patient exposure?
Underexposed.
Patient is, yeah. So your film, okay, again, your image is going to look okay, but because of that increased distance, your beam is going to be less intense. Remember your inverse square law. It's going to be less intense, so now the patient's going to be absorbing that radiation. So to answer your question, should I adjust for 10 or 15 degrees? Not a big deal. Okay? We're more concerned with more steeper angles. Okay? I say greater than 30, you should adjust. All right. So which radiograph A or B is a higher quality, and what factors lead to the substandard radiograph? Okay? Which is better? We're dealing with extremities, right? What type of contrast do we want?
High contrast.
High contrast. What is high contrast? What does that mean?
More black and white.
More black and white. Okay,
So
so
B.
which is more black and white?
B.
B. A is a little bit, it's high, this is low contrast, more gray, so it's a little bit more washy. So I agree, B is a better image. You guys agree?
Mm-hmm.
Okay. Now, do you guys understand high and low contrast and when it is acceptable? You do?
For abdomen versus
Okay, why do you, so for abdomen, you want high or low contrast?
Low contrast.
Why do you want low contrast?
To see the other anatomical structure.
Anatomy, okay? So the analogy that I make, and I think, again, I've only shared this with part of my students, or if you were in my intro class. When you are looking at contrast, as technologists, we're dealing with a palette of grays, okay? We're not dealing with color, we're dealing with grays. So when you're x-raying body parts like the hand, it's just basically skin and bones, literally skin and bones. So do I need a lot of grays or do I not need a lot of grays? You don't need a lot of grays, so that's high contrast. Now going back to what you were saying with the abdomen has your large bowel, small bowel, stomach, spleen, liver, you've got your spine. Okay, so you've got all these different anatomical structures of various densities. More body parts. Now think of it as like coloring your anatomy book. Have you guys ever colored an anatomy book? Or just a coloring book altogether? For each part of that image, you're using a different color. So you can distinguish one part from another. So for a large body part like the abdomen, where I've just named off all those different anatomical structures, I don't have color, I have grays. So I need a certain type of gray to identify and distinguish all those different body parts. So to go back on what you were saying, for the abdomen, I'm going to need more grays. Okay, more body parts. So is that high or low contrast?
Low contrast.
That's low contrast. The chest is another example because I've got my heart, my lungs, my ribs, my spine, okay, liver shadow. Okay, there's a lot of body parts to that too, right? So is that high contrast or low contrast?
Low contrast.
Low contrast. I need more grays to identify all those different structures. So in those terms, you always think about it of a coloring book, but we deal with black and white and different shades of grays. All right, so the foot is just skin and bones, has to be high contrast, mostly black and white. All right, AP oblique foot. AP oblique foot. For the foot, we are doing a medial rotation. Medial rotation. We don't do external rotation. The most common position for an oblique is medial rotation of approximately 30 to 40 degrees. 30 to 40 degrees. Again, example of this patient sitting up, leg is bent, maintain modesty. Maintain modesty. The central ray is going to be directed at the base of the third metatarsal. Okay, third metatarsal. Entire foot is going to be visualized. Third to fifth metatarsals are free from superimposition. Tuberosity, okay. The tuberosity of the fifth is going to be well demonstrated in this view. You need to write that or highlight it or do something with it, okay? The tuberosity of the fifth metatarsal is best demonstrated in this position. Okay, what else is demonstrated in this position?
Calcaneous.
Sinus tarsi. Sinus tarsi. Okay. Calcaneous, yes. Sinus tarsi. Okay. The two most important structures for an oblique foot is for the tuberosity of the fifth metatarsal and then the sinus tarsi. Okay. This is an alternate oblique. It's not very common. This is an alternate, but now we are rotating or obliquing the foot on the opposite side. This is not a good view except if you are looking at the base of the fifth metatarsal or the structures towards the first metatarsal. This is the best view. This isn't a good view because look what happens to all the bones and structures. Even in an oblique, there's a lot of superimposition. Okay? And that has to do, again, with the arch of the foot. This is why we do the opposite oblique. It opens up the structures much better than you do with this oblique. Okay? So although it can be done, this is not a common position.